One of the most important issues at this AAO are the treatment regimens, and there's discussion 1 or 2 months injections. And when we look at the Navilas system and when we look at the studies Dr. Freeman did, where he compared combined treatment with bevacizumab and the navigated laser, and our study, where I want to show you the results now, where we compared ranibizumab monotherapy to a combined treatment of ranibizumab and navigated laser. It's already in somehow proven that there is a treatment option that can stabilize the vision without the need of too much injections. So the navigated laser system is a very unique system, as we have the opportunity to use FA data and imaging data for a navigated laser treatment. You heard that already. In Munich, we had the opportunity to work quite early with the Navilas system. In the beginning, that were the pre-anti-VEGF times. It was very important to prove the accuracy of the system. We did studies on that together with the colleagues from San Diego, and we could show that it is a tool with high precision and safety. And as a by-effect, we could show that the pain the patients feel during treatment is much less than with conventional laser. In one study, we compared a 36 patient who had standard focal macular laser and navigated laser patients, and we could show that the feeling of pain was significantly different compared to the conventional laser. But most important, that comparing conventional laser to navigated laser, there is a difference in the outcome, in the visual outcome. In this study, we could show that those patients who had navigated laser treatment for diabetic macular edema had a 50% reduced retreatment rate after 8 months, and this is something of importance. As we all know, times have changed. In Germany, we have for 2 years now ranibizumab approved for DME treatment. And in somehow, we are very happy that we have this option because we have the opportunity to improve the vision of our patient. But we all know that the price is continuously injecting. And therefore, one important issue, how we could reduce this injection burden. Navigated laser is a very nice tool for that. For those who do not work with the Navilas system, I'd like to show you a short video about that, because you can implement data from other imaging tools, for example OCT, but also use the EFA, and you have a high amount of safety. As you can see, you don't need the contact lens, which makes it very convenient for the patient. And the results, as I showed you already, appear to be better than with conventional laser. So what we did in the study we performed in Munich is that we compared ranibizumab monotherapy with 3 injections of upload and then pro-Renata scheme with patients who were treated with 3 ranibizumab injections followed by navigated laser and then also treated by PRN. So in this study, we included 34 patients in the combined group, 32 in the ranibizumab group. And the main outcome measures were the number of injections needed after upload and the change in best visual acuity after baseline 2 months 12. So here you can see the study design. So all patients got 3 injections, and the first group, the combined group, had an additional navigated laser after the 3rd injection, and then we waited, if necessary, re-injected, and the others only had ranibizumab monotherapy. First, I'd like to say it works in somehow, and I'd like to show you this by a patient example. Here we have a diffuse type macular edema. The patient gets his injections, and you see how the macula gets flatter, this fluid gets reduced. And after the 3rd injection, we performed the macular laser. So we performed in somehow modified grid treatments where we saw microaneurysms, we treated them, but those areas of diffuse thickening we treated with grids. And when we follow this patient, we can see that 3 months after laser, even 12 months after the laser, the vision is stabilized and the macular edema hasn't reoccurred in this case. So when we look back at the study data we see in the beginning all 3 groups were very good comparable. What was different was the outcome of the patients. In those patients, in both patient groups, the retinal thickness reduced very comparable. There was no significant difference in both groups, but also the visual acuity in both groups developed very well after the injections. They had a good improvement and kept the gain of visual acuity over the 12 months of the study period, but there was a significant difference in the number of injections needed. Here we can see a little bit on how the vision improved in these patients. When we go a little bit deeper in, those patients who gained 10 letters or more were a little bit higher in the navigated or combined laser group compared to the monotherapy group, and also those who gained more than 50 letters. There were more in the navigated combined treatment group compared to the ranibizumab monotherapy. This was not statistically significant, but it gives a hint towards the better outcome of those patients. A very important, significant difference in both study groups was the number of injections and the retreatment need. As you can see from this Kaplan-Meier chart, is that from the combined treatment group, 65% of patients did not need any re-injection after the upload phase. In the monotherapy group, only 16% of patients had the luck not to need any injection anymore. And also the number of injections needed was significantly different. In the monotherapy group, the patients needed an average of seven injections in the first year. In the combined treatment group, it was only one injection after the upload of 3 injections. So this is a very, very promising result, and we look forward from the study we heard that is going on now that this will confirm this. In somehow, it has also confirmed by the data of Dr. Freeman in San Diego. He treated patients with bevacizumab and then added, after 3 to 4 injections, navigated laser. And when we look at the outcome, this is quite comparable to that what we achieved in our investigation in Munich with the ranibizumab patients. In both groups, even with ranibizumab or with bevacizumab, the number of injections after the upload phase was very low, below 1 after the upload, and the visual acuity of patients was at least as good as after the monotherapy. So what we can say from these pilot data is that with the combination of navigated laser and anti-VEGF therapy, we are able to achieve as good visual outcomes and anatomic outcomes as with anti-VEGF monotherapy, but we have the high benefit of a very good reduced retreatment rate, more than 50% less retreatments in the combined treatment groups, and this is something that will be very important for the future, and therefore we are lucky that we can use this beautiful tool. Thank you very much.
Marcus, what are your thoughts on this whole thing of geographic atrophy and AMD with all the anti-VEGF therapy? Is that another potential side effect that we can avoid? Is because in diabetics, this can become a 10-year issue of anti-VEGF.
Maybe, but we all know that we, not only in AMD, but as well in diabetic macular edema, sometimes we have fibrotic changes after a while. And there, for example, there are data, I don't know if you heard about it, about the angiofibrotic switch, where you reduce the levels of VEGF in the eye and get an overdose of CTGF, another factor which is important for fibrosis, and this induces in somehow retinal fibrosis. By adding the laser, you don't need as much anti-VEGF as you need right now, and therefore you can prevent in somehow such changes a little bit, with another side effect that you don't have this up and down from macular edema, which might be a factor as well for changes like this.
Very interesting.
Thank you very much.
So